let's move this. Okay, so hi everyone. My name is Lisa Faxén, as Eva just said, and I'm an infectious disease physician at the hospital here in Uppsala, and also a PhD student in Thomas Tengdel's group. And the focus of my thesis is individualized and rational use of antibiotics in difficult to treat infections. Just have to make this a little bit smaller. Okay. And today I will talk about one of my projects, which is a population pharmacokinetic model of benzyl penicillin in patients with infective endocarditis to support individualized dosing strategies. Infective endocarditis is infection that targets the heart valves, as you can see in this picture. So the bacteria, typically Staph aureus or different kind of streptococci, mainly those from the oral cavity, infect the heart valves and forms vegetations, so-called vegetations on the valves. And they consist of bacteria, inflammatory cells, platelets, and fibrin. And this is a severe condition with high mortality. In Sweden, there is a mortality around 10%, and there's also a high risk of complications. Around 40% of the patients gets heart failure. They can also develop valve perforation, that the valves are destroyed by the infection, which can result in the need of urgent surgery. We also often see embolic events, and that is that fragments of the vegetation detach and follows the bloodstream to different organs and causes lesions in those. For example, the brain, the spleen, the kidneys, or the skeleton. And approximately 30% requires surgery. So it's a severe and challenging infection. And we treat this condition with intravenous antibiotics in high doses for a long time, usually up to 4 to 6 weeks. And beta-lactam antibiotics are our primary choice since they are considered effective and well tolerated. And today we're going to focus on benzyl penicillin, which is one beta-lactam antibiotic, and that is one of the most commonly used in this condition. And since we are treating these patients with high doses of antibiotics for a long time, it's not uncommon that we see side effects at the end of the treatment period. And this might, for example, be myelodepression, which means that the bone marrow works less good. So we can see, for example, that the count of white blood cells, the leukocytes, goes down, and the platelets and the red blood cells. But if we change to another antibiotic class, this is reversible. Sometimes we also see beta-lactam fever after several weeks with beta-lactam treatment. And that means that the patient gets fever from the beta-lactam treatment. And the mechanism is unknown, but this is also reversible if we change to another antibiotic class. We also sometimes see allergic reactions. And earlier, beta-lactams has been regarded as very atoxic, and that there is almost no limit, toxic limit. But in recent years, there has been several reports in, for example, neurological side effects from beta-lactams in high concentrations. So there is a limit. And this group of patients with infective endocarditis is a very heterogeneous patient group. And we see a large variability between patients regarding age, renal function, body weight, albumin levels, etc. And these are all factors that affect the pharmacokinetics of antibiotics and the resulting concentration in plasma. And we would really like to take all these factors into account, but in clinical practice today, we don't know how to do that. There is insufficient evidence regarding how to individualize dosing in order to optimize effect and reduce the risk of side effects. And the current dosing regimens, more or less today, are based on a one-size-fits-all concept, with the exception of severe renal impairment, when we reduce the dose, but we don't really know how, to what extent we should reduce the dose. Dosing strategies today in clinical practice can be divided into flat dosing, covariate guided dosing, and individual dosing. And the most basic way of dosing is flat dosing. Then we are giving the same dose for a certain condition to all patients. Covariate guided dosing, then we take into account that different covariates, for example, if a patient is, for example, very obese people or people with renal impairment. So then we group the patients according to this. So that's, and we do that for in certain situations and for certain drugs. And the most precise way of dosing is individual dosing, and that's usually called MIPD, or model-informed precision dosing, where we have a population pharmacokinetic model, and we insert the patient-specific information, the plasma concentration, covariates, dosing history, etc. And the dosing software can predict individual concentration curve and a recommendation of the dosing strategy. But that is, of course, time-consuming and costly, so we cannot do that for all patients. And today we do it in certain cases, and especially for antibiotics with a narrow therapeutic interval. And before we move on, I think it might be good to refresh our knowledge about PK and PD. So pharmacokinetics, or PK, is the concentration curve over time. And it's usually explained by the sentence, what the body does to the drug. So the shape of the curve is defined by important physiological parameters as the volume of the distribution and the clearance. And the volume of distribution describes how the drug is distributed in the body, and clearance describes how fast it is eliminated from the body. Can we see? Pharmacodynamics describes the effect of the drug and is explained by the sentence, what the drug does to the body. But in our case, when we are talking about antibiotics, it's what the drug does to the bacteria. So this is tells us about the relationship about concentration and effect, and an important measurement for that when it comes to antibiotics is MIC, minimum inhibitory concentration. PK/PD is the relationship between PK and PD, and describes the link between the antibiotic exposure after a given dose and the effect on the bacteria. And usually we talk about 3 PK/PD indices, or PK/PD targets, which describes different types of exposure in relation to MIC. And that's time, the free concentration remains above MIC. That's one. Second is the ratio of the peak concentration to MIC, and the ratio of AUC, area under the curve, to MIC.
Lisa, could you explain what is area under the curve? Because it seems to be an important concept for PK/PD.
Yeah, so that's the total exposure, the area, this area under the curve, and divided by MIC. That's that PK/PD index. And here is the peak concentration, and here is the time that the concentration remains above MIC. So okay, and for beta-lactam antibiotics, it's the first PK/PD target that is the most important. So it's the time the free concentration remains above MIC. That's the most important. And in endocarditis, it's not very well defined what the target should be, but consensus right now is that it should be at least 50% of the time that the concentration should be above MIC. Okay. The objective of this project was to characterize benzyl penicillin pharmacokinetics and associated variability in infective endocarditis patients and evaluate the impact of patient covariates. So describe the pharmacokinetics, build a model, and do dosing simulations to predict untested scenarios. We included patients at 3 Swedish hospitals in Uppsala, Gothenburg, and Lund. And we included adult patients with suspected or verified endocarditis that were treated with benzyl penicillin. And we collected plasma samples for antibiotic concentrations weekly within one dosing interval up to end of treatment. And during the first week after inclusion, we took 6 samples within one dosing interval, and the following weeks, 3 samples per dosing interval. The samples were then analyzed with liquid chromatography tandem mass spectrometry, and the resulting concentration were calculated. So then we have the concentrations, and then we should build this population PK model. So what is then that? A population PK model describes the pharmacokinetic parameters and variability in a patient population, and is summarized with mathematical equations. So in this case, the PK parameters is, for example, clearance and volume of distribution, and our patient population is the endocarditis patient group. To build this model, we used NONMEM, which stands for Nonlinear Mixed Effects Modeling. And this is a gold standard software for population pharmacokinetics, pharmacodynamics, and pharmacometrics. And it allows simultaneous analysis of population level parameters. So the typical parameter for the population, the fixed effects, and individual variability, the random effects. So this makes it to a powerful tool, and it makes it possible to identify covariates that influence drug levels, predict how different patients may respond to the same dose, and optimize dosing for both groups and individual patients. So the POP-PK model is developed from clinical data. So you have your data set with all the concentrations and information regarding dose and time of dose and concentration measurements, and some patient information regarding body weight, age, renal function, etc. And the model typically consists of 3 different components. First, we have a structural model, which describes the skeleton of the model. How many compartments do we have? You always have a central compartment into which the dose is given and from where we take the plasma samples. But you might also have 1 or several peripheral compartments, and then which communicate with each other. And then you have a statistical model, which describes the variability in the observed data. And usually we talk about 2 kinds of variability. We have the variability between individuals. That's the inter-individual variability, and it's on the parameter level. So different patients in this population has, for example, different clearance. And then we have variability within individuals, and that's called residual unexplained variability. And that's on the observational level. So that describes the difference between the observed value and the model predicted value. And that mismatch might be explained by model misspecifications or measurement errors. And then you have the covariate model, which describes the impact of different patient covariates. And they are included in the model if they help explain the differences between patients and can reduce the variability. And this is just a slide to show the two types of variability. Here we have the between subject variability, where we see that each individual has different profiles of the concentration curve. And then we have the residual error, which is on the observational level. And non-MEM can then include both these variabilities in the calculations.
Lisa, can you just remind me quickly every how often the samples were taken for the concentrations?
Oh, sorry, I didn't hear your question.
If you can remind me quickly every how often the concentrations were taken samples from. Yes, forgot,
okay.
Sorry.
So the first week after inclusion, we took 6 samples within one dosing interval. So we took them just after end of dose, after 30 minutes, after 1 hour, after 2 hours, 4 hours, and just before next dose.
Okay, thank you.
And in the following weeks, we took one directly after dose, one before next dose, and one just between those two samplings.
Okay, so three per week after the first week was done. 6, yes. And then 3. Okay.
Exactly. Yeah, totally true. So yeah, how to perform this model building. The strategy is in the model development is performed in a stepwise manner with one change at a time. And for each step, the maximum likelihood objective function value is calculated, the OFV. And here we calculate the likelihood that the data comes from the model. So the lower the OFV, the better the model fit. So in each step, you do a kind of likelihood ratio test, a hypothesis testing, where you evaluate if the model without the new parameter and the model with the parameter, if there is a significant difference in model fit between those two models. And if there is a OFV drop of at least more than 3.84, then it's a significant improvement in model fit. And then you include the parameter and move on and test new parameters. So in every step you evaluate just one additional parameter. And the model selection is also guided by graphical diagnostic plots and Gonzalo fit plots and visual predictive checks to evaluate the predictive performance of the model.
Gregory has a question. Maybe he wants to take it in now within the topic.
Please.
Yeah, I have just a short question on the answer you gave to Eva just before. It was about the dosing, and you said you sample just after giving the dose.
Yeah, that's true. Yeah.
And I was I was motivated to do usually just before doing the dose, not just after.
Yeah, we have both directly after and both, and also just before next dose.
Okay. And how close it is to the administration? Is it 5 minutes afterwards, or is the minutes
exactly.
after?
Yeah, around 3 to 5 minutes after a given dose. And it's the most important in this sampling procedure. It's that the time point is exactly defined. So that's that helps the software to calculate the model.
Just a follow-up question, and to me, it feels that 3, 4, 5 minutes are very close to the administration, and I was wondering if you had knowledge about like after what amount of time you consider that the drug concentration is homogeneous in the blood system.
Yeah, you administer it into plasma, so it's in my opinion, it's in a very short time you reach the maximum concentration.
Okay.
But yeah, it might depend on like where you also take the sample from. Usually we take it from the central venous catheter, and then I think it's a very short time after the administration and the peak concentration. Yeah. Okay. So when you build this model, you usually start to find the structural model, then you move forward to the statistical model, you add the covariate relationships, and then you challenge the model with evaluating the predictive performance. And then you might go back again to re-evaluate steps. So there might be that you move a little bit back and forth in this procedure. So what did we find? We included 33 patients. Our aim was to include around 30 patients to be able to build a robust model. The median age was 75 years. 32 of those 33 patients were men. And this imbalance is known in this condition. So it's mainly men, but usually the ratio is around 70%. So this is a bit more like than that. We collected 301 plasma concentrations, and that's then the total concentrations because we cannot measure the free concentration at the moment. Median trough concentration, which is the concentration just before next dose, was 3.3 milligram per liter with a quite large range between 0.4 and 59 milligram per liter. And regarding the structural model, we found a 3-compartment model to best fit the data. And regarding the statistical model, we found inter-individual variability on clearance, all the volumes, and one of the in-compartmental clearance. And regarding the residual error, we found it to be that the proportional residual error best fitted the data. And in this case, it means that that the residual errors increases with increasing concentrations. When we looked at the covariate model, we found eGFR, which is an estimate of the renal function, that was an important covariate for benzyl penicillin clearance. And it reduced the inter-individual variability from 58% to 19%, so almost to a third. So this is nice, but maybe not so. It is kind of expected because as benzyl penicillin is a hydrophilic drug, it's mainly eliminated by the kidneys. Albumin, the protein that binds the drug in plasma, was a significant covariate for the central volume and reduced the inter-individual variability from 24% to 13%.
What is the central volume, Lisa?
Central volume, that's a volume of distribution. So yeah, it's the central
okay, you mean by compartment, so the central compartment.
The volume of the central compartment, that's true. Okay, so and then you evaluate this on the way with graphical evaluations. And a typical plot is, for example, basic goodness of fit plots, where you plot how observations relate to population predictions and individual predictions. And you can also evaluate the residual error model, and you look for misspecifications or systematical trends and things like that. And I think this is also a fun plot where you plot the observed data versus individual predictions and population predictions. And this is like the truth. You see the true observations taken for all the patients plotted against time after dose. And here you can see how the model predicts the concentration for the population and for the individuals. And you can see that the model is quite good to predict the true concentrations. And
just a short question, why did you choose to have a log scale for the observers predicted? Is it just like to fit everything in one plot, or what is it?
Yeah, it was. Otherwise, it was very hard to see. It was. It made it more clear. Otherwise, it was a very narrow graph. So that's for the visibility. And this is also on the log scale. This is a visual predictive check plot where you challenge the model to show its predictive performance. And here you have the concentration on the y-axis and the time after dose on the x-axis. And the blue circles are the observations, and the solid and dashed lines are the 5th, 50th, and 95th percentiles of the measured concentrations. So 90% of the observations lies within the dashed lines. And the shaded areas are the 95% confidence interval of the model predicted corresponding percentiles. So the goal is that the lines lie within the shaded areas. So this looks okay. So we have the model, even though there are some small refinements that needs to be done. But then the next step is to look what is the target and what target attainment should we aim for. All the patients that we included had an identified pathogen in the blood, and it's mostly streptococci from the oral cavity, and other gram-positive pathogens. And in this column, you can see the susceptibility breakpoints for those bacteria. So to simplify a little bit, I choose a MIC target of 0.25 milligram per liter, which was the highest susceptibility breakpoints for the pathogens observed in this population. And we assumed a free unbound fraction of the benzyl penicillin of 35%, since we were analyzing the total concentration. And then we could see that 100% of the patients achieved 50% of the time that the free concentration was above MIC. And so that is good, since that's our goal today. We could see that almost 100%, 94% achieved 100% time that the free concentration was above MIC. And I think this is also a bit interesting that 1/3 of the patients achieved a free concentration 100% of the time that was above 8 times the MIC. And this is sometimes considered as a toxic threshold, that you shouldn't be above that level. And the patients with impaired renal function were overrepresented in this group. And just some words about the clinical outcome for this patient group. And the study was not at all designed to evaluate any correlations between target attainment or concentrations and the clinical outcome, but it's still interesting to see that for the patient group, I think. So just to highlight some things is that the unplanned heart valve surgery happened for around 30% of the patients. Around 12% died during the treatment period, and adverse events were seen in around 9% of the cases. So it's clearly a severe condition. To conclude, a population PK model of benzylpenicillin in infective endocarditis patients was developed. The inclusion of covariates, eGFR for clearance and albumin for the central volume of distribution, significantly reduced the individual variability of these parameters. And the developed model, informed by plasma concentrations, may provide support in the future for optimized and individualized dosing strategies. So what's left to do? We will do simulations to describe PK profiles for different patient groups regarding renal function and albumin levels, and evaluate target attainment with different targets and different patient groups and different dosing strategies. And then we want to define how this model might provide support in the future for optimized and individualized dosing regimens, maybe MIPD, or maybe covariate guided dosing stratified by levels of renal impairment. Who knows? To be defined. Yeah, I think I'm done, and I'm happy to take any questions.
Thank you so much. Thank you, Lisa. Gregory is ready to shoot up the questions. So we will, first of all, I just want to say thank you so much for your presentation. I feel like I got a really good understanding of how you guys work with this kind of studies, that are important to know, especially when you have these drugs that are given in the hospital and you have this very small window where they might become toxic, but you need to have enough of it for it to do what it's supposed to do. So really cool. Thank you so much. So Gregory, go ahead.
I was wondering if you took into account communication, because I guess since it's like endocarditis is mostly like it's not only benzylpenicillin you're taking when you're treating patients. It's like gonna be with gentamicin, gonna be with vancomycin, it's gonna be with I don't know fluzacillin or like other very annoying drugs. And I was wondering if you took this into account, if you intend to do it, and how and how.
If they were treated with additional drugs.
Combinations.
Combinations. Yeah, we have that. We have like in the data file, we have recorded all drugs that they had, antibiotic drugs that they have had during the same time. So that's also on the future list to maybe evaluate the impact of that. But they were, I think they, in this group, they never had two beta-lactam antibiotics in the same time. But might be aminoglycosides or sometimes used in combination with benzylpenicillin.
Yeah, because I know in many places that they do use combinations, in particular to treat endocarditis because of how hard it is.
Exactly.
So do you think some of these patients might have been on purpose being given empirically combinations of antibiotics for the endocarditis?
Yeah, I mean, when you have like this viridans streptococci, it's you commonly use benzylpenicillin in combination with, for example, gentamicin or other aminoglycosides. So, yeah, that might be in some cases, but it shouldn't. I don't think it should like have an impact on the concentration of the benzylpenicillin, but maybe on the outcome.
On the model, yeah, on the outcomes, yeah, I guess it would be something to look at. Gregory, do you have any more questions? Yes, do you want to go ahead? I have some questions, but I can take them later, so go ahead.
I had another question. I think your workflow is really good right now, and you're doing it right. I was wondering if you could do it another way, which is the patients which are dying, like what are they dying of exactly? And I was wondering if it was septic shock or if it was something else. And so right now, what you're modeling is prediction of the ability of kill bacteria, essentially.
Exactly.
And I was wondering if you could go towards something that predicts the probability of doing a septic shock, which is the killing thing.
Yeah.
And I don't know if it's too deep. And I don't know if, like, when you model the two in the end, you're doing the same thing, or if there's a difference between the two of them. I know it's not the classical way of doing it, and it's really complicated one, I guess, to do. But have you ever thought about it, and what are your thoughts about it now that I said it?
Yeah, that sounds like an interesting idea also to add on the list of future work. I think it was mainly complications due to the infection on the valves. It was like heart failure or destruction of the valves and yeah. So, like, how do you say, cardiogen shock mainly. Yeah.
You mean, I suppose, as for example, bacteremia, right? So they died of
mainly
of the damage that the infection did
exactly.
on the organ rather than having a septic shock or something like that.
Yeah. So that's so it's more a hemodynamic shock, due to the destruction of the valves and rather than the septic shock. But and I just think when it comes to the outcome that this is 33 patients, it's a very, very small amount of patients. So it's hard to draw any conclusions, I think, but it's a very interesting thought to look at this. Well, I'll take that into account. I can just also mention that we also looked at the interoccasional variability during the treatment period, because they were treated for many weeks, and we were very interested if the pharmacokinetics change over time. Like often we see that when they get better, but we couldn't really see that this was informing the model in a nice way.
Do you have a question?
Yeah, so I just had a more general question about like when you're doing model-informed precision dosing, what the sort of workflow is there. So like at what point do you start, doing that?
Yeah. So I think I have one more picture or slide about that. Was this your question? What?
Yeah. So sort of like once you
exactly
take some samples, like what kind of information are you actually getting out, and how do you use that?
Yeah.
When
The traditional way of sampling and TDM is that you take your sample and your therapeutic window, and then it's very important that the sample is taking it at a certain time point, like just before next dose. So that is usually how we do today in many conditions and for many drugs when we do TDM. But MIPD, the model-informed precision dosing, then you need a population PK model for this population that your patient belongs to, for example, a septic patient or endocarditis patient. So you have this population PK model for this drug, and then you insert information from your individual patients, the covariates, and then the plasma concentration and dosing history. And then you use this Bayes estimation equation to calculate the individual prediction curve for this patient, and you can calculate the optimal dosing strategy. So that's mainly how it works. So you need so you need a software that can combine the information from the population PK model and the information from the individual patient, and you need to be able to analyze plasma concentrations, and you need there are a lack of population PK models. So for example, for benzyl penicillin, there are very few and the results diverge. So there are many things that needs to be at hand to be able to do MIPD, but it sounds really nice.
Yeah.
We're doing it for vancomycin, for example.
Yeah. Sorry, just a very short follow-up question. So, like, when you get the predictions from the model, does it suggest to you what changes to make, or are you the one sort of whoever's running the model deciding what changes to make?
Yeah, exactly. Someone needs to interpret the results. And for example, for vancomycin, it's the clinical pharmacist that helps us with this. And then they gives us advice of how, what concentration interval we should aim for when we take our trough concentrations. So in clinical practice today, we as physicians get help from the clinical pharmacist that does this, uses this software.
Thank you.
Gregory?
And it's really impressive and works very well. I had one patient some weeks ago with a really bad renal function, and then we usually we dose vancomycin once every 24th hour when we have bad renal function. But with this help, we could give a dose every third day, and we really the patient didn't have impaired renal function, and we reached the optimal target of the concentration. So that was very cool, I think.
My question was around how you use the PKPD indices, especially in your case, you're using the time spent of the MIC. And the value you get is usually determined from in vitro experiments, and it says we did an experiment over 24 hours, and we think that 50% of the time is sufficient. And then you check in the clinical and you say, are you satisfied with this or not? And I was wondering, when you use this, do you use when you provide the time spent over MIC, do you provide the last 24 hours before sampling, or since the beginning of the administration, or does it even really matter is what I'm asking? Yeah, that's it. When you're saying time spent over MIC that you managed to achieve, over which time period are you talking?
Yeah, that's a good question. Now it was like an average. So this was really simplified. But of course you could, you would mean that in the beginning, or during which part of the treatment period, or?
I think what he means is, yeah, if you have any idea of that 50%, if it's all the time or from the beginning you give the dose until the end of the dose and before the next one, right? Something like that.
Yeah.
That's what you were asking.
Because my understanding is that when you do the in vitro, is that you test it for 24 hours, and you see that, okay, when we manage to reach 50% of time over MIC, we manage to diminish by 99% the amount of bacteria at 24 hours. So in your case, when you're saying that it's the time spent over MIC, is it the first 24 hours as well? So you expect this 99% reduction, or you didn't reach that first, and then but since you have 2 days of experimentation, you're always under the MIC at the second day. So there's this difference between what is done in vitro and what is done in clinical. And I was wondering if this difference impacted the thinking and how. And it's a very broad question. I just don't know if you even think of it, or how to think of it. I just don't know.
No. No.
It makes sense to, if you say 50% of the time is over MIC, is that 50% of the time, the first 50% of the hours of the treatment within a given dose?
Yeah, I think that this target comes from that the concentration has been measured in the middle of the dosing interval, and if the free concentration is above MIC at that time point, then you have reached.
Percent of the time, because it's the
exactly
middle of the. Okay. Interesting.
Yeah.
Gregory, do you have any more questions?
No, I can stop now if needed.
All right, sure. Okay, so we put the whole hour, even though it was just one presentation. But I do have some questions that are perhaps a little bit more general. You know, I know Gregory has a background in PKPD as well and working. I come from between Gregory's talk at the retreat and your talk, I now understand a lot more how these models work and how you guys work with it. My question. When it comes to, for example, you were mentioning about the benzene penicillin, that it has a lot of side effects that seem to be related with that particular treatment, because you said that those outcomes can be reversed if you change to another antibiotic. So my question is, how often within the treatment with benzene penicillin you guys actually change to another antibiotic because of this, or is it better to actually try to adjust the dose rather than change the treatment? Because I assume these models are looking for a way that you can adjust the dose so those potential bad outcomes with that antibiotic are minimized. Isn't it maybe better to think, can we change to another antibiotic?
Yeah, very good question. The side effects from benzyl penicillin, usually we see them after several weeks. So for shorter treatment durations, we really don't see any side effects, what we know at least. So when it's pneumonia or things like it's treated within 1 week or something like that, that we don't see it. So it comes after around maybe 4 or 5 weeks, then we can see those more of those side effects. And then, as you say, we sometimes have to change to another drug, but we prefer to keep benzyl penicillin as long as we can, because it's very effective, and usually it's very well tolerated. So we see even more side effects with other drugs, quinolones and linezolid and whatever, daptomycin and so on. So we prefer the beta-lactams as long as we can use them. But we don't know what are driving the side effects. Is it the total exposure? Is it the top concentration? Or that is still to be defined. And we hope to, as you say, be able to tailor the dosing to maybe in the future avoid some of the side effects. So yeah.
I guess once you start using this model-informed precision dosing, if it really reduces, you could start see the other way, like looking back.
Exactly.
Do we actually see less of these side effects if we have this more controlled dosing?
Exactly.
Things like that.
But I think you need a larger population, because I think this is too small to evaluate that. But that's our hope. So yeah, retrospective study maybe.
And just I didn't fully understand this idea of the 3 compartments. And can you maybe summarize what those compartments were? Because they were also some of the main results had to do about a covariate that had to do with a compartment. So I think it's rather important. Yeah. Can you explain to me what does that mean?
Yes. So the 3 compartments, and you have one central compartment. It's more or less your blood volume, and might also be it's not always corresponding to a real physiological compartment, but it's where you're taking the samples from, and then we have 2 peripheral compartments, and it's it's like a schematic explanation of how the drug behaves, and that it's not only in distributed in one compartment, but also other compartments. So it's a little bit abstract. But then what we could see with albumin levels, which is the protein that binds benzyl penicillin and keeps it in the blood volume, it's that this the level of albumin could inform or like us to be more sure about the estimation got better of the central volume, and that makes sense since it's a protein that binds the drug in this volume. So yeah.
And so now this central compartment that you mean is let's say that even if it's a virtual space or a physical space, is the space where you want most of your drug to be in order for it to do the thing that it needs to be doing. Where these other compartments is like states where that drug might be, but they are not. And when they are in those compartments, they're not really doing what they need to be doing, which is attacking the bacteria.
Yeah, it's hard to say. You can imagine it like compartments with less blood, like
supply or less blood
or
reach.
like for example, it can be more like if you have plasma volume and then you have like tissues that are less hydrophilic, and how to say that can be different compartments. But
okay, where the drug might be because it's okay. I think
so
I
how
understand.
the like drug is distributed. So yeah, it's like less blood-like fluid, so to say.
I think I get it more or less.
But I mean, it's this where we really want the drug to be in the central blood volume because that's where the infection is. But it's it would also be interesting to measure the concentration like in the vegetation, because the bacteria are really hidden in this. It's almost like a biofilm because
we're not talking even about biofilms. Yeah, is that actually the drug that is passing through there, like reaching really the
Yeah, so the dream would be to evaluate the concentration in the like vegetation compartment, like
just a crazy question about this, like because I know, for example, that they can reach the heart not invasively through like for example, when they put a stent, they go through the groin up and stuff. Is there a way to take a physical sample of a valve infection for this kind of infections?
Yeah, that you mean that you will measure the concentration, or
I mean, can you reach physically the place where the infection is happening? Yes.
Yeah, that's a really good question. Apparently, somehow we do it because many people get rid of the infection. But that's why we're using so high doses and for such a long time and intravenously administered. So we are like we take into account that they are like hard to reach the bacteria.
Yeah, very interesting. All right, 2 minutes. Just my last comment, because I was recently in South Korea and we were talking about new approaches to treat infections, and difficult to treat infections in this case. And there was this guy. He was an engineer, and he was showing that he's developing like a sensor that you can put in it's like malleable. You can have it in the patient all the time, and then it can take samples of drug concentration constantly. Like a little bit like similar to the glucose thing that they can be put there, and but developing also to maybe measure antibiotics and to do individualized therapy.
That sounds
have
amazing.
you looked into this, or have you heard of those things for endocarditis or something?
Yeah, I've heard of it from at ESCMID. There was a presentation about that. That was an Australian researcher talking about almost the same thing, and I think it's super interesting. And that might be something in the future. It's to
get into the hospital
implement.
And you basically get a thing there that it will measure. It's the same as you will get the electrocardiogram, I guess, or something like that.
Yeah. And imagine you have the infusion at the same time that gets
will trigger, right? It will just like, it will see how much is happening. It's like,
Exactly.
we are low on penicillin.
Yeah.
Should it
Like
a
for
little bit more?
diabetes when you have the pump. So yeah,
exactly.
that's the future, Eva.
Yes, great. Then with that, I think with an outlook to the future, we will close today's webinar if nobody else has any questions. I think some people already had to leave. They were saying very nice talk, and I agree. It was great, and I really love that we had this very engaged conversation and discussion about the topic. So I think we learned a lot today. Thank you so much, Lisa, for presenting your work. And last but not least, I am just going to, even though there's not a lot of people left, but I just want to share the news that we have the opening registration for the Uppsala Antibiotic Days, which will be on June 15th and 16th of next year. And in this web address, bit.ly/Uppsala Antibiotic Days, with the capital letters in the words, you can go in and register. And we're really looking forward to have a very, very multidisciplinary conference with a lot of different topics. For certain, also PKPD, like Lisa was presented today, among other clinical-based things, and diagnostics, new pathogens, complements to antibiotics, etc., etc. So we're looking forward to have you there. And with this last bit of advertising on our end, I would like to say thank you to Lisa. Thank you to all of you for listening, either live or in remote later, playing this, and hope to see you at many more UAC events in the future. Thank you so much. Thank you, Lisa.